let me just introduce you. So good morning, everyone, and welcome to the Tele Trauma Grand Rounds. Today we have Dr. Constantine Saclarides, who's a Trauma and Surgical Critical Care Fellow at Ryder Trauma Center, Jackson Memorial Hospital, here with us presenting a case titled Mass Casualty Incident in Miami. So I'm very excited to hear the presentation. So over to you, Dr. Saclarides, to start.
Thank you very much, Ms. Kumar, for the introduction. And I want to thank all the panelists for attending, as well as everybody else who is in attendance here. I'm very, very honored by the Pan American Trauma Society to have this opportunity to present. As I said, my name is Dino. I'm a second-year trauma fellow at Ryder. And although this was initially publicized as a mass casualty incident in Miami, I think perhaps a more appropriate title would be a multiple casualties incident in Miami. As many of you very well know, the true definition of mass casualty would suggest that the number of casualties overwhelms the hospital's capabilities in terms of personnel and resources. But I feel very proud to be at an institution that has very robust backup systems in place to be able to manage incidents like these. But this was one of those very busy call nights, and I thought that it would provide for a good discussion. So the objectives, first to discuss triage variabilities amongst different institutions of those panelists who are attending, to assess management of resources in mass casualty incidences, to review systems for calling in backup personnel, physicians, nurses, and to assess post-operative care after mass casualty or mass casualty incidents. I'd also like to apologize to everyone. I would have preferred to have been giving this in a suit and tie. I actually was on call overnight and just got out of a vascular trauma. So apologies for the blood on my neck and on my shirt. But perhaps if I'm invited back for another, I would have loved to present in a more formal fashion. Without further ado, we'll step into the first case. It was about 10 p.m. on January 5th. When we got word that there was a shooting at a video recording for a rap video, the rapper French Montana. There were 10 gunshot victims, and we were told that multiple of them would be coming into our institution. There were 2 helicopters that were arriving on top of our hospital, each with 2 patients. And these are the patients that we received. The first arrived with agonal breathing, was intubated. A left chest tube was placed for decreased breath sounds on the right. The patient was tachycardic to 142 with blood pressures in the 130s over 90s and on secondary survey. As you can see in the schematic, there was a left thoracoabdominal gunshot wound. The way I've labeled these, red suggests an anterior wound and blue suggests a posterior wound. It was more of a blast, really. It was probably a ricocheted because there were about 7 fragments associated with this one left thoracoabdominal wound. And then there were 2 right gluteal wounds. We got a chest x-ray that showed a missile on the right side of the chest to suggest a transmediastinal trajectory. And before I get into the actual way that each of these was managed in this talk, I primarily just want to see how the different experts in the room would have triaged these patients, who would have been taken to the operating room first, how everybody would have called in backup personnel, and I'll eventually get to how these were each managed. But first, I'll just describe how they presented. The second patient also presented with agonal breathing, was intubated in the trauma bay. There were decreased breath sounds on the left-hand side. The left chest tube was placed. The patient was tachycardic to 105. Blood pressure was 130s over 80s. On secondary survey, there were 2 gunshot wounds to the left chest, 2 gunshot wounds to the left arm, and there was no left radial pulse distally. Here's a chest x-ray that shows after the patient is intubated and a chest tube was placed on the left. The next patient presented within about 2 or 3 minutes after these first 2 in the second helicopter. This patient also had agonal breathing, was intubated for airway protection, had bilateral chest tubes placed for decreased breath sounds bilaterally. Patient's heart rate was 96, blood pressure was 118 over 64. And on secondary survey, there was a single gunshot wound to the right back. The patient was noted to be unable to move his legs shortly before he was intubated. And this is a X-ray showing 2 chest tubes on the right side and then 1 chest tube on the left side. And the 4th patient was in the helicopter with the 3rd patient that arrived. I was also intubated in the trauma bay. Bilateral chest tubes were placed for decreased breath sounds. And the patient was tachycardic to 120 with a blood pressure of 135 or 100. And on secondary survey, a patient had multiple gunshot wounds to the chest, to the abdomen, also to the right arm. And so here we have these patients. Patient number 1, again, with thoracoabdominal gunshot wound, transmediastinal trajectory, blood pressure of 142. I'm sorry, heart rate of 142, blood pressure 133 over 96. Patient number 2, also tachycardic with a gunshot to the chest. And I misspoke, I'm sorry. This patient had a palpable radial pulse in the left radial. This patient number 4 had no palpable radial pulse distally, as well as a gunshot wound to the chest and the abdomen. And then this patient number 3, single gunshot wound, not tachycardic, but unable to move his legs. So I'll pause there, and I'll see from the experts and panelists in the room, what is everybody's thoughts on who should go to the operating room first?
Thank you, Dr. Saclarides. Dr. Antrek, do you want to go first?
Yeah, so one of the questions I had in my mind when you put mass casualty incident was whether it was really a mass casualty incident. Even the, Dr. Hockman is here, but with the Boston Marathon bombing, I forget how many casualties they had, but the EMS system is so well prepared that that was, is bad, but it was really multiple casualty incident. And Boston actually has a tradition preparing for mass casualty incidents back to World War II, when they, before the Coconut Grove fire, they had carried out scenarios and drills expecting that Germany was going to attack the East Coast. And that tradition has lasted all the way through to the 21st century. So in this case, it's not, as you said, it's really multiple casualty incidents. And then we have to know, how many surgeons do you have? How many trauma teams do you have available at this point? 2 or more than 2? Or that makes that is, you need to know that what your resources are to prioritize. So we need to know that. And the other point I'd raise, because you're talking about secondary survey, it means that each patient was stabilized by the resuscitative measures. That implies that you wouldn't proceed to the secondary survey unless you've corrected the immediate life-threatening problems. So it presumes that. So we'd have to know what your resources are and what the vital signs are of these patients after the resuscitative measures. And based on the way you presented on your slide, I assume that the first patient, blood pressure 142, rather pulse 142, that's after the chest tube was placed. So that's a bit concerning. And but without having those variables answered, I think it'd be difficult to decide who goes first.
I appreciate those questions, Dr. Untrack, and I'll address both of them. In terms of first about the resources that are available at all times in-house at the Ryder Trauma Center, we have 1 trauma surgery attending in-house 24/7, a trauma senior trainee. Usually it's at least 1, if not 2, second-year trauma surgery fellows. And on some nights it is a chief resident, but on that particular night it was myself, a second-year trauma fellow. We have capability of having 3 trauma surgery attendings who are always scheduled to be on backup. 1 is first call, 1 is second call, 1 is third call, and then a cascade of calls thereafter to be able to call in as many trauma surgeons as necessary. We actually had many more than that who were available within 10 minutes, and I'll just describe that in the coming slides. We had 5 trauma surgeons that were actually there. And then secondly, I really appreciate the point you made, Dr. Intract, about yes, a true thorough secondary survey does not happen in a unstable patient to get to the operating room. This was a very brief examination of where the apertures are to determine trajectories. But we, of course, perform more thorough secondary surveys once these patients were in a better, more stable condition post-operatively.
Right. I'll defer to the others about who goes first, but based on what you said, okay?
Dr. Supa, would you like to make any comments?
Yes. In this situation, I think all patients may need operation, but the first one seemed to be in shock because his heart rate is more than his systolic blood pressure. So his shock index is more than 1. And I think that the useful tool at this point to quickly check these patients is to use a fast examination. They all got intubated, so airway has been taken care of. They all had chest tubes, so I think breathing is okay at this point. So the major determinant at this point is boost circulation is worst. We take that guy first. I think fast exam to check for blood in the abdomen and to check for cardiac tamponade would help us decide which one to take first. The one with cardiac tamponade or hemoperitoneum should go immediately to the OR. And based on clinical, I think number 1 may be in shock, and the bleeding point may be in the abdomen. But if the patient had no obvious cardiac tamponade or hemoperitoneum, and they got better after fluid resuscitation, I think we can investigate on them to check for the trajectory and bleeding in chest or abdomen. Vascular injuries, if it's not bleeding, it can wait. Okay. So clinically, I would take number 1, but I think I would like to get the ultrasound, the fast exam, before deciding. Thank you very much.
Thank you, Dr. Supa. Dr. Hodgman, do you want to make your comments?
And I would add, just after that point, we performed focused fast exams on all these patients, specifically a subxiphoid pericardial view to rule out exactly what your concern was, which is cardiac tamponade, and none of them had hemopericardium. Our institutional norm protocol is not to perform abdominal fasts in most of these penetrating traumas to rule out hemoperitoneum. But to rule out hemopericardium, we examined all these patients and none of them had hemopericardium.
So first, I think Dr. Untrar has more experience with mass casualties nowadays than what we have in Boston because he has been in Iraq many times. It's kind of funny what the situation in Boston during World War II, because there is a park near my house, and I am like 30 miles from the coast with bunkers that were created during World War II in preparation for a bombardment from the Germans, but 30 miles inland. But anyway, this is first of all, do you know how many more patients were you getting? This is the first question, because if suddenly you are going to get 30 more patients, some of the patients might not be a candidate to go to the OR, as harsh as it sounds. So that's the first question. One of the things that happened during the Boston bombing is that we have orthopedic pushing us to let them take some patients with lower extremity fractures to the OR, and we needed to hold them down and argue with them because we didn't know what else we were getting, and a head or torso injury would take priority. So it sounds to me that you have plenty of teams there to bring back. I don't know, you might have the surgeons, do you have the nurses and OR staff to run 5 or 6 rooms? So that tends to be the limiting factor, many times more than the number of surgeons that might be available. So you need to more or less get to know those variables before deciding which patient goes first. If this is all the number of patients that you are going to get, and you have the resources, probably all the patients, almost all of them together in different rooms, but but otherwise, I am between 1 and 2. If I am alone and I don't have resources, those are the two that appear to be more seriously injured. The problem with this is that you do not know where the bullets ended. One of the X-rays show a bullet that appears to be a rifle bullet. And I don't know if a rifle was involved, but if it's not a rifle, and this was only a pistol, this is, I am willing to bet that the pistol being used is a 5.7 by 28. This is a pistol that can carry a lot of ammo, like 20 rounds bare minimum, and it's a very high velocity bullet. And it's more similar to a rifle bullet than a regular 9mm bullet. So the injuries might be much more extensive than what they appear to be initially. We are used to handle gunshots in urban trauma centers, but there was this, I think it was in Texas, this was a psychiatrist that went crazy in a military base and shot like 20 people. That's the type of handgun that he used. And one of the reasons he uses it is because it has very large capacity. And two, the bullet is a high-speed bullet. To give you an idea, 9mm travels around 1,200 feet per second. And an M16 is like around like 3,600. This is like 2,200. So, and that's because it's a shorter barrel, but the destruction is much more significant. So these bullets in the groin might end up in the liver, so you don't know. And so that seems to consider if you're suspecting this type of gunshot wounds. So they will probably be more serious than the garden variety gunshot wounds that we normally see in the ED. That's all I have.
Thank you, Dr. Hodgman. Dr. Kobe, would you like to make your comments as well?
You already said all comments. So just three comments. So first, did you start massive transfusion protocol? And two, any bleeding from the gunshot wounds? And last, going to OR is easy for you, but deciding where to open is difficult. So I will start the first exam and how much blood leaking from tracheal tubes. So if they are nothing to breathe, so I will go to CT scan. Thank you.
Thank you, Dr. Kobe. Dr. Saclarides, back to you to continue.
Yes, I'll address each of those points. Regarding the first question, MTP was indeed activated with all of these patients. Secondly, in terms of bleeding from the apertures themselves, the gunshot wounds, the first patient did not have brisk bleeding from the thoracoabdominal wound. Patient number 2 had more brisk bleeding, but it was not arterial from his gunshot wounds. Patient number 3 did not have particularly brisk bleeding, but patient 4, and this is the one that lost radial pulse distally, did have significant bleeding from the gunshot wounds. And then the third question that was asked was about ease of access to the operating room. We're very fortunate at the Ryder Trauma Center to have 6 operating rooms that are dedicated to our trauma hospital, and they are within a 22-second walking distance from our trauma base. So from the spot where patients are initially brought in by EMS crews, to bring that stretcher from the operating room is about a 20-second walk down the hallway with full OR staff and capabilities. In each of our 5 trauma bays also have the lighting and capabilities to perform major abdominal surgery as well.
Thank you.
And there was a previous question that was asked about how many more casualties we were expecting from the incident. And I really appreciate that question. We were told that it was maybe 5 or 6, but it wasn't clear. The number kept changing, but we were expecting at least 4, with more coming. Well, it seems multiple people have suggested that patient number 1 should go to the operating room first, based on the pronounced shock, the tachycardia. And before I get to who went first, I just want to add something else into the mix. Shortly thereafter, after these 4 patients arrived, we actually were informed that there was another gunshot victim. This was within just several minutes, that there was a patient that was riding his motorcycle on the highway and then shot himself in the face in attempted suicide. And so he was brought in, agonal breathing with blood in his airway. The anesthesia team was having difficulty getting an endotracheal tube in, even with video laryngoscopy. His heart rate was 90, his blood pressure was 150/76. And on a very brief secondary survey, not a thorough one, but a brief one, he had obvious multiple facial fractures, exposed bone, and shrapnel around his face. And then actually, several minutes after we were informed about this self-inflicted gunshot to the face, we were actually called by our obstetrician colleagues on the other side of the hospital. This is about a 5 to 8 minute walk, that there was a 39-week pregnant woman who was in a motor vehicle collision. She was seat belted, and she arrived. She was transported by EMS. Her airway was intact. She had bilateral breath sounds, but she was tachycardic. And on the physical exam, her abdomen was tender. She had a seatbelt sign, and she had very concerning fetal decelerations, for which the OB team was emergently taking her to the operating room for a crash C-section. And we were called to evaluate to see if part of her tachycardia and shock was secondary to a hollow viscous injury or other intra-abdominal organ injury. And so to further describe this evening, within about an hour, we had these 6 patients. The first 4 were gunshot victims. Number 5 was a self-inflicted gunshot with what seems to be a surgical airway. And then patient number 6 is on the other side of the hospital with a seatbelt sign, tachycardic from an MVC, on the way to the operating room for a crash C-section. And so I want to pause there and see if there are any change in thoughts about how to triage and who should be managed first.
Thank you, Dr. Sackler. It's quite a night you've had. Okay, I'm going to go to Dr. Kobe first this time. Do you want to make your comments first then?
Me?
Yes.
Oh, okay. I would choose number 1 would be first. He is less stable. So, and next is number 4 or number 6. So I like to confirm how would they respond to the infusion or some blood?
Minimal response to transfusion. Patients remain tachycardic, and actually all of them progressively more unstable even after starting MTP.
Okay. Okay. So I have to choose 1 patient, go to OR, 1 patient. If the physiological signs are unchanged, so I choose number 1. But so difficult to select these tough patients. Sorry.
Thank you, Dr. Kobe. Dr. Supa, do you want to go next?
Yes, because you have a lot of OR available in the rider. I think number one should immediately go to the OR for exploration. Number five, even if he had airway problem, but I can see from the chest X-ray that he was intubated already. If intubation is in already and he's breathing well on the ventilator, I would try to pack the bleeding wound, maybe intraoral packing or outside or bandaging to try to stop the external bleeding. And number four, I think he needs OR too because of the location of the gunshot. I think he is likely to need a laparotomy to stop the bleeding. And number six is easy because you have OB people with you. This lady, she needs a C-section to get the fetus out to resuscitate the baby. And we can do the ELAP and let the OB take the baby out, and then we can explore the abdomen thoroughly after we remove the fetus. And other patients who remain stable can go to CT scan, like Dr. Kobe mentioned. So I think I would still go with number one to the OR. And if you have people and room available, number 4 and number 6 can go to OR immediately without any further investigations. Other than that, if you can control the airway of number 5 and pack the bleeding, 2, 3, 5 can go to CT scan. Thank you.
Thank you. Any other thoughts or commentary about order of triage?
Well, if I may, the last two are like a red herring here. They say, okay, hold on. Let me say this. The hallmark of a true surgeon is frequently wrong, but never in doubt. So this is the reason I'm making these comments. But 4, 5, and 6, I really wouldn't care too much. 5, based on your description, is the surgical airway. Get the surgical airway, cricothyroidotomy, 30 seconds, and move on. After that, probably would call ENT that they are usually in-house and tell them to pack the mouse, and I just move up to the next patient. Number 6, I would ask preferably to do a vertical incision for the C-section. I am pretty sure that they will do a transverse incision no matter what. And after that, they have to deal with the issue when it happened. But even if it can have a bowel injury, it can have a mesenteric injury. A mesenteric injury might be bleeding, and that might require the intervention of the trauma surgeon. But if it's just only a bowel injury, I would send one of my intermediate level residents, put the staplers all around, and we will do that last. That patient goes, leave the abdomen open, staple the bowel, and we deal with that later. You're still stuck with the 4 that you have first, but these last two for me is just, at this time, considering everything that you have, it's just a distraction. Those patients should go last in the priority list. And if you have more people coming in, I will send those people to take care of these patients after those primary issues were sorted out. The other four, they're kind of hanging in there. You're telling us that they are becoming more unstable. And this is where the experience of a surgeon counts, because there are intangibles that are very difficult to define, but is based on experience. Is kind of like when you do those cases, you say, okay, this goes first, and after that, we tend to be correct, and people will ask, how do you decide that? And people say, oh, it was a gut feeling. It's not a gut feeling, it's a pattern recognition of having seen too many patients. And patients that look good, suddenly it doesn't look so good, and say, why did you decide to take this one first? Because it didn't look good, but it's very difficult to define. So without seeing the patients, without being there, it's very difficult for us to guess which one. But I would guess that the trauma surgeon there decided on one that is not evident now, and probably that person was correct, and probably was correct because he has the years of experience behind. But that's all I can say.
Okay, and then I'll, in fact, I was thinking all the same things that Dr. Hockman just mentioned. Trauma patient number 6, I would just urge the obstetrician, please make a midline incision, and then I would send the senior resident on call for the general surgical service to go down there, scrub in the case, and explore the abdomen after they get the baby out to see maybe it's just a perforated uterus or whatever, but impress on the obstetrician. It's easier for them. Got to do a midline incision so the general surgeons can explore to save the patient's life. Don't mess around in this case. And I think if it's a real emergency, a dire emergency, I think, I don't know that most obstetricians would have a problem with that, but I would send someone not on the trauma service, just senior resident, and get one of the attendings to poke his head in. Number 5 depends on how he shot himself. Sounds like he shot straight up rather than straight back because he made it to the hospital. And as Dr. Super said, I can see the endotracheal tube. It looks like, it was curving in at the neck level that somebody did a cricothyroidotomy to get him intubated. But if it's just, just facial wounds and he's otherwise okay, the plastic surgeons can deal with that, or the ENT surgeons can deal with that. So I'd send those away very quickly. With the other 4, number 1 seems to be in the worst shape, but I'd like to know if I'm going to take him to the OR where he's bleeding from. So if you spend 10 seconds looking at the heart with the ultrasound, you can spend another 5.5 seconds looking at the abdomen to see is there blood there. He got shot twice in the buttock. So where do the bullets go? They're still in the buttock. Do they go up? Where'd they go? I would still, and especially after some time has gone by, look at the abdomen with the ultrasound, and for that matter, the chest as well, because he could have clotted off his chest tubes, accumulating blood. You can get an answer right away, so you know who is bleeding in the worst way that you need to get to first. And I would say that you should be able to take 2 people to the OR at the same time, at least 2 full surgical teams, 2 trauma teams. And so 1 would probably go. And patient 4, which one was the one not moving the legs? Patient 3? Not moving the legs.
Correct. 3's not moving the legs.
Okay, and it depends on what his status is. It looks like he got shot in the belly and got a blast wound to his spine. And patient 4 needs likely either thoracotomy, laparotomy, plus an brachial artery shunt, which one of the vascular residents can come by, vascular fellow can come by and do that while you take care of the 2 team that one, while the trauma team takes care of either the chest or the abdomen or both, whatever's necessary. So you have to be there with all the tools at hand to make the best judgment. But I would plan whichever 2, and then after that you can temporize with the others. And then at this point, if you're more than 40 minutes out after the actual gunshot, the assault, then you're very unlikely to get anything but a yellow or a green patient. Anyone that was really severely injured, threatening airway, breathing, or circulation, and if they don't make it in within 40 minutes, they're very unlikely to survive. So anyone that makes it in as time goes by is more likely to be yellow. In other words, something that you can temporize. And by the time they come in, you can still leave the OR, leave the abdomen open, plan to do that, get them off the table into the ICU, and get ready for the next case. So I would use that approach, not, doing full closures and, doing the simplest thing for those cases.
And if I may, one more thing. Now 40 minutes has passed. You should be able to obtain more information by now. So the first one, do we have a pelvic film? What did the rectal exam show? That he had blood in the urine? Because with the gunshot wound to the pelvis, there are not too many things that are immediate injuries, either the rectum, the bladder, the iliac vessels, or the femoral vessels. So knowing that extra information is critical. How many bullets are we talking about? This is an exit and entrance. So normally we at TAP we do something we call it, we kind of like created the name. We call it a extended primary survey. When somebody has multiple stab wounds or gunshot wounds, we do the primary and very quickly look for holes before doing anything else, because sometimes missing a critical hole, you see a gunshot wound in the front, you're thinking is that, and it has a bad one in the back. The patient becomes unstable, you go to the OR, and the one in the front is not the one causing the bleeding, it's the one in the back. So you have to have an idea before you react how many holes you have. So by then you should have x-rays and see how many bullets, and the number of bullets and the number of holes should be an even number. So that will give you an idea of a gross idea, and it's easy to be wrong, but at least you will have an idea of trajectory and what organs could be involved, and will help you to plan the incision. So I don't know, this is something that you probably have this information that we don't have now. And so we are all guessing. Thank you.
Yes, I do indeed, and I'm intentionally holding off for a satisfying end to the hour talk. And I'll pause there and actually transition a little bit to more of a discussion on management of mass casualty, because although this isn't a true mass casualty, as we've all discussed and agree that this was a multiple casualties incident, I think it does open for good conversation just about systems that each hospital has in place for calling in extra personnel for resource management, for managing multiple casualties. We actually had a total of 20 trauma activations that shift, that 24-hour shift on top of these patients that came in through these 5 trauma bays here at the Ryder Trauma Center. And just speaking a little bit about mass casualty, I think I feel very fortunate here training here, because there are multiple attendings that have a great deal of experience when it comes to mass casualty and preparedness. Leading amongst them, perhaps, is Dr. Mauricio Lin, who had multiple years of experience in the Israeli army and has written extensively on it. And so I want to thank him for mentoring me for this talk. And several of these slides that I'm about to share with you are from his own talk, but he gives a lecture that we really enjoy hearing, that he titles The 10 Commandments of Management of Mass Casualty Incidents. And we'll talk about all of these, but we'll just briefly go through them, perhaps to spark a little discussion in the remaining 15 minutes that we have. But first, in a mass casualty or multiple casualties incident, to call in extra personnel, the backup surgeons, more nurses, more staff. 2, control patient flooding. It's difficult to triage these patients if they present in mass. There should be a way to manage the masses of patients that come in. 3, have open spaces available to bring in stretchers, personnel, resources, equipment. 4, control ambulance flow. There should be a circular flow of ambulance in and out, rather than a system that can create clogging of the pathway. Number 5, of course, perform triage. Number 6, identify and register these patients. Dr. Lin appreciate a key message in this talk that he gives, is that the registrar that registers patients in the system is just as important as the surgeon performing the surgery, because unless these patients are registered in the system, they can't get orders, they can't get blood, MTP can't be activated for them. Number 7, controlling the media. With so many of these incidences, we have dozens of crews that are on our parking garages, videoing down to the trauma bay from the 7th story of the parking garage. And so making sure that the message that is portrayed is uniform, and also that they don't clog the path of ambulances. Handling families. Oftentimes this includes taking pictures of patients for identification, especially if there are multiple that can't be identified. 9, controlling the event itself and the inflow of personnel who are trying to help. And then 10, what he refers to as sharpening the axe, or drills. And so how to call in backup personnel? Well, as I mentioned here, we have a fairly robust backup system. On the night of the event, within about 15 to 20 minutes of getting the first call, there were 5 trauma attendings that arrived at the trauma bay, including the 3 who were on backup. 1 on the call, very generous attending, Dr. Kaufman, who stayed after her long shift. Dr. Namayas, our chief, who came in and helped coordinate things. Dr. Martos, Dr. Wetstein, who was on call, who had a very heroic role in coordinating all the efforts. I was the trauma fellow on, but I have excellent colleagues that I work with, and with just a simple text, 3 more arrived, and this was 11 p.m. and all of them had to work the next day and had already worked that day, but arrived within minutes. And although we have one attending anesthesiologist dedicated to trauma, there were 3 other that presented in our backup system. For trauma surgeons, as I mentioned, 3 on backup at all times on any given night. But even on top of the 3 backups, we had an extra 1 or 2 that came in. For anesthesiologists, there are always 4 attendings in-house at any given time, 1 for trauma, 2 for the main OR, 1 for OB, and then 4 on backup. So a potential of 7 or 8 that are available at any given time. And then our nursing backup system is somewhat of a complicated algorithm, but the nurses call upstairs to our trauma floor, as well as the ICU. And some of those nurses are floated downstairs to help. And then the void created upstairs on the floor is then filled with the nurses that are called in. That way we have more immediate response from nurses, as well as aides to help with splinting, and so on. And then registrars, we even have a backup system for registrars to call in extra personnel to help put these patients in the system, print stickers, organize their charts, so that we can actually manage what needs to happen with them. And so in terms of how to approach resource management, I want to pause here and just hear from some of the different experts that are on call at your respective institutions. How do you control patient flooding? How do you create open spaces for ambulance flow? How do you all perform triage? We have a fence around our hospital. Again, this is to control patient flooding. If a bomb was to go off at the airport, or if there was to be a mass casualty incident with one of the multiple cruise ships that comes in and out of Miami, a fence was built to be able to control inflow and outflow of patients and ambulances, extra spaces that we have available, as well as gear. As you can see over here at one of the entrances to our emergency department, we actually have containers that have stretchers and wheelchairs for purposes like this. If we just have large numbers of bodies that show up, we have ways of managing them. And Dr. Lin has been excellent as in coordinating drills to practice this. And then we have alternate spaces where we can put stretchers and triage and place patients depending on how critical they are. This is an aerial view of our hospital, the trauma bay being over here, and different means of bringing ambulances in and out. So I'll pause there before moving on to see how is it at your respective institutions that that these issues are addressed in terms of resource management.
Thank you, Dr. Saclarides. Dr. Anchak, can I come to you first for this? Dr. Anchak, you're muted. We can hear.
Yes, well, in Iraq, it's a much smaller population with a closed base, and we have about 1,500 people on base, but we can receive patients from outside. And as you pointed out in your presentation from Dr. Lin's book, you know, the trauma surgery, the trauma surgeon in mass casualty incidents is just the tip of the iceberg. The whole, almost the whole exercise is logistics and triage. It's mostly EMS and the administrative people at the hospital doing all the other things that that you mentioned. And we're on my base every month. We have a mass casualty incident exercise planned by the military people using the security staff at the base that, you know, to set up to see to all the logistical needs. It's almost all logistics, getting the patients triaged appropriately into the right place, preventing the clogging of the vehicles, all that sort of thing. So we do all the things that you mentioned, and the people in charge are not the surgeons. The surgeons are only in charge once the patient gets into the not just the trauma bay, but the ER. Sometimes they can send a yellow patient into the trauma bay and a red patient out into the main ER. And unless the surgeon, you know, goes and looks, they'll miss that. But once before they get into the ER, it's the rest of the iceberg that deals with those other functions. And in fact, it's really not my specialty, and I'm glad to have them, you know, when they say what they do and they set up and they make all the contingencies. I'm glad they're there, because they're the ones that, you know, without them, it's going to fail. The exercise is going to fail.
Thank you, Dr. Anchak. Dr. Silva, do you want to make your comments, please?
in my hospital in Bangkok, my hospital name is King Chulalongkorn Memorial Hospital. We had the last mass casualty event. It was 8 years ago. It was a bomb in Bangkok, and we received like 27 patients in one day. Most of them came within the first hours, and we had all the problems you listed here. And one point that I think is interesting is registering the patients, because on that night we had a confusion. We got the wrong X-ray and wrong blood transfusion because the ID system didn't work very well on that night. So nowadays we have a pre-registered ID for mass casualties patient. When the patient came in, you have already ID available. You just have to tag the ID with the patient, and I hope this will cause less confusion for identifying patient. Thank you.
Thank you, Dr. Supa. Dr. Gopi, would you like to make any comment?
Me? Great systems. I can't imagine if I were in Japan. So one question, who decided to start this mass casualty mode or options? So attending surgeons or some fellows or resident to start this protocol to attending surgeons?
It's the trauma surgeons.
Surgeon, okay. So you received the 6 patients. So this is the how long does did it start this mass casualty incident? So just after patient comes, or you see some 2 or 3 patients?
It's a great question. We didn't trigger the usual pathways for a true mass casualty response. In this case, we just treated it as multiple casualties because we had the personnel arrive and were able to manage it just as a regular night. But it would be, if we were to trigger all these other things, rerouting the flow of ambulances, opening up spaces, and so on and so forth, it would be one of the attendings, either one of our trauma surgeons or somebody from the ER side. But several of our attendings are very much so embedded in the hospital's emergency and disaster plans when it comes to mass casualty incidences.
Okay, thanks. So, so in Japan, I can't imagine this terrible event. So we only accept these 2 severe trauma patients, not 6 one time. If I had 6 severe trauma patients, we will try to the patient transfer another hospitals. Thank you.
And some of these patients were indeed transferred, or not transferred rather, but some of the walking wounded, if you will, there were 10 total patients who were shot that night. And we got every single one of the critical ones. All of the ones that required critical care and surgery came to us, and the EMS system in Miami knew that. But the walking wounded, those who were less critical, went to other hospitals. I want to be respectful of everybody's time because we only have about 5 minutes left. So I just want to share with you what actually ended up happening with each of these patients in the following 2 slides. First off, recognizing that managing post-operative care can be quite difficult in these patients because oftentimes it requires take-backs. Many of these patients require damage control, and then the next day the trauma system has to function as it usually would for all of the new traumas that the city has to bring. But for patient number 1, this patient had a splenectomy, a gastrorrhaphy, a left diaphragm repair, and then for the transmediastinal workup was found to have a tracheal and esophageal injury, which required a right posterior lateral thoracotomy on ECMO, and those were repaired. And then the patient was found to have a left splenic flexure injury, either thermal or just a missed injury from one piece of shrapnel. This was actually presented last week in an excellent presentation by Dr. Carter, one of my colleagues who's was in that case. The second patient had I'm sorry, this is a typo, just a left humerus repair that was fixed on day 1. There was some hemorrhage control from branches of the brachial artery on day 0. And the patient was discharged home on day 5, did very well. Patient number 3 with the gunshot wound to the back had a right diaphragm repair and packing of the liver during the index procedure and a complex hepatography. On post-op day 1 was washed out and closed, and then had a prolonged ICU course on a ventilator and had a tracheostomy day 15, but is doing much better now. And is tolerating a minimal pressure support and trach collaring. Patient number 4, perhaps the sickest of them all, had a distal pancreatectomy, splenectomy, multiple small bowel resections, a sigmoidectomy, a right brachial artery repair with reverse saphenous vein graft. Postoperative day number 1 went back for a small bowel anastomosis, a colostomy creation, and then was closed on postoperative day 2, and unfortunately has developed an intercutaneous fistula in the aftermath. Patient number 5, the one that shot himself in the face, had a surgical airway, as everybody recognized, and had an emergent cricothyroidotomy. The mandible was fixed on day 4, and the patient is now tolerating trach collaring on the floor, ambulating, and is soon to start a diet. And then the OB patient on the other side of the hospital had an emergency C-section. The fan and steel incision was already created. And so after I was scrubbed into the first case, went across the hospital so that the rest of the staff could stay and manage these other casualties, and explored the abdomen through the fan and steel incision that was already created as best as I could. And fortunately, there are no injuries, and she and her baby did very well and were discharged home 2 days later. There were a total of 6 takebacks that happened over the course of the next 3 days. And 10 total operations after the index operation. In terms of the order of cases, I know I didn't address that, but fortunately, because of how dedicated our attendings are and our very robust callback system, and I think just very heroic management by Dr. Wetstein, who's on this call and is a military surgeon himself, I think our triage was excellent, and the flow of cases in and out of the operating room was fairly smooth. So we basically took them as they arrived. Patient number 1 arrived first. We took him to the OR shortly thereafter, accounting for trajectories and even number of apertures and gunshots, as was questioned earlier. Patient number 2 was taken next to another operating room. Within 5 minutes, these next 2 arrived almost simultaneously and were taken to the operating room with individual attendings. So we had 4 operating rooms going at the same time. Shortly after these cases started, Dr. Wetstein, who was coordinating this whole event after getting control of the liver bleeding, and patient number 3 stepped out. He got an emergent surgical airway and then went back and coordinated the other cases. And then shortly after we completed the first case, within the hour, went across the hospital to explore the abdomen on our OB patient. So this was, I really appreciate everybody's input. This was a good conversation. And I thank you to my mentors here at the Ryder Trauma Center, Dr. Namias and Dr. Wetstein, for coordinating care for all these patients. And fortunately, at this moment, they're all still alive.
Saturday, that was a really amazing presentation. I learned so much from it. I think I'm just going around to all the panelists for like a round of final comments. Dr. Hodgman, would you like to start off?
Well, I have to say that I was utterly impressed by whatever you have at Riders is fantastic. The way that you have the capacity to deal with all this trauma and how you are prepared really is, I don't know, it's top of the line. I don't know how much we can offer because we don't have this multiple casualty routinely in Boston. A few things that to add to that triage, we identified problems in the past with mass casualty. First, everybody calling the hospital to find out if their help is needed. So we created a system as a system-wide notification that we sent to people, you need to come in or you don't need to come in. And after that, all calls get directed to a call center, and basically the notifications will be by email within 20 minutes, repeated 20 minutes, to decrease anxiety and to prevent these phone calls from clogging the system. Because one of the things that happen is that the system and the phones in the hospital get completely clogged when this happens. The other thing that we identified, and there's a solution, and that this is something for the people living in the States might be important to know. When you have a mass casualty incident, the cell phones stop working, sometimes for the sign to prevent activation of an explosive. And sometimes it's because they are so overwhelmed, the network is so overwhelmed that they stop functioning. So there is something called FirstNet, which is a subsidiary of AT&T. And so that network have priority, and it's only for first responders. It's police, firefighters, and EMS, except trauma surgeons qualify for that. So I have two phones. One phone is with FirstNet. So if something were to happen, that doesn't come down. Even if there is an order to take down the cell system, not to allow for detonation of devices or communications or terrorists or whatever, the FirstNet is still active and you can call your backup. The other thing that we decided to do in mass casualty incidents, and I see that you have something similar in Jackson, is the lockdown. The hospital goes in an immediate lockdown because you need to prevent, if you have a terrorist attack, the terrorists from coming into the hospital and creating more havoc in the hospital when the victims are coming. And it looks like you have even a better system because we had to put security and police in the corners to block the traffic. And as Dr. Supa mentioned, all the patients get the generic name because otherwise you have problems with misidentification, particularly if somebody die and you notify the family that the patient died and it's somebody else. And the other thing that we change, and I obviously in a place like Ryder, you don't need to change this, but in smaller places, you probably do. Initially following the Israeli model, the most senior surgeon was doing the triage. But we don't have too many senior surgeons, and the more senior surgeons most likely will be needed in the OR. So one thing that we change is, and this is probably similar to what Dr. Supa was describing, the ED is in charge of triage instead of being the surgeons, because the surgeons are needed in the OR. And the trauma surgeons take control of the operating room, because this is another thing. Riders, you are mostly trauma, but in places where you have other specialties going on, you will have the orthopedic surgeons, or I don't know, the nurses. When can I start my carpal tunnel? Why I'm being delayed, whatever. So the trauma surgeon take control of the operating room, the chief of trauma or the delegate, and all the cases stop, and the OR cannot be reopened for routine cases until the trauma surgeon says so. And that avoids part of the confusion. So those are things for smaller trauma centers to consider. And that's all I have.
Thank you, Dr. Hodgman. Dr. Supa, would you like to make your final comments?
Thank you very much, Dr. Dino, for presenting this interesting event. I'm a little bit sad because Dr. Lin didn't give me his book. It looks very interesting. Thank you very much.
Thank you, Dr. Supa. Dr. Anchak, would you like to make your final comment?
Yes, maybe Dr. Lin has it in PDF format that he can just sort of give out to the few of us here. So that maybe Dr. Dino, if you could look into that. But anyway, about the charts, I think it was Dr. Hochman mentioned, or maybe Dr. Super brought this up, but we have those old-fashioned paper folders, the old-fashioned charts. Inside, there's for mass transfusion protocol or walking blood bank, we have that sheet, and then there's a red bracelet with already a patient number that goes on the patient, and all the papers in that file have the same sticker on it. So without thinking, it's all done. The patient, because they're not going to stop and go to the registration desk. They're going to come straight back to the trauma base. So we have that all set. and then eventually they get transferred over to other to proper charts. But and then also Miami, I'm a little surprised. Is the University of Miami the only hospital that can receive trauma patients? You have Jackson Memorial. I think there are a few other of those hospitals around where you have fellows that present cases at this conference. But I think the big cities, they all have robust EMS systems simply to avoid overloading one hospital at the same time with all these cases. In Boston, there's Tufts, Boston City, and Boston Medical Center, Mass General, all within, well, those three of them within a close range, and then one a few miles away. And the EMS systems are very good at making certain that the patients get distributed so that they don't overwhelm any one hospital at any one time. And that's how they got such good results in the Coconut Grove fire and the Boston Marathon bombing. So I'm surprised that your EMS system hasn't done that. I think they should, really. I mean, it's if you have and I think you have the resources there.
It was perplexing to all of us that night, but we were very happy and honored to receive all of the patients. But for whatever reason, some of the other hospitals in Miami, I don't know if it was an issue of diversion or capacity on their end, but fortunately we were able to host and receive everybody that was sent our way without issue.
Oh yeah, but it might be different next time. They shouldn't get too used to it. That if it really gets bad, they need to, and the other hospitals have to appreciate that it's going to cut in hurt the bottom line a bit for a few days, but that's part of the game.
One problem that we have during the Boston bombing, the plans for evacuations were very well designed, but they never took into consideration that the people will live on food. So the streets got blocked. And so the ambulances were dispatched in the order that Dr. Untrich is describing. Okay, you go 111, all the trauma centers, only to find out that they couldn't travel, and they were redirected by the police officer, who obviously was the most junior one, that was directing traffic on the street. So the ambulance ended up going to trauma centers, or places that were not even a trauma center, far away from the city, because they were redirected. So all these plans, many times they don't work because of these extra circumstances that I don't know. There was construction on the bridge, so they cannot go. So they go to. So that might be part of the situation and why you go to all of them, but or would be by lack of planning too. But
Thank you, Dr. Hodgman. Thank you, Dr. Untrack. Dr. Kobe, do you have any final comments to make?
Okay, I am very grateful to invite me as a panelist, and congratulations on your great service and great saving for them. So last, I have two questions. How many trauma things join this event? And last, these surgeries, these patients go to OR in 1 hour after their arrivals. Almost these patients. Thank you.
The first question, there were 5 trauma attendings that were present,
Okay.
and 4 fellows.
Okay.
Great. And I'm so sorry, I didn't hear the end of the second question.
So how long these patients going to OR? So I think in less than 1 hour or less than 30 minutes.
Each of them was in the trauma bay for no more than 5 minutes before going to the operating room.
Okay, I can't imagine these situations. Thanks. Thank you very much.
Thank you.
Thank you, Dr. Thank you, Dr. Saclarides, for this amazing presentation. And yes, thank you to all of.
Thank you, Dr. Kumar, for hosting this, and thank you to everybody for your commentary.
Really nicely done, Dino,
Thank you, Dr. Kaufman.
and nicely done that night. You being able to handle that, you know, and run over with the OB and the liver like that was a huge part of the success as well. That would not have happened, let's say, on a trauma green night. Let's put it that way. So you really did a bang up job. And one of the things, there are a couple of things that we can talk about because I'm looking who's on the line right now. Supa, how are you? I don't know if he's still there. Lynn is not the only one, by the way, with disaster experience. But the big thing about that is, if you notice, like, you know, one is that the trauma surgeon is needed in, this is a little bit different than a mass casualty where, like, if you look at Las Vegas, where they had 115 patients at who presented, very few were actually operative. This was more like an operative mass casualty, as opposed to an exercise and triage, et cetera. But the it was interesting, like, once the trauma surgeon is committed, and think about the other places that don't have the backup and the redundancy, there was so much more to be able to maintain that level of triaging and treatment in resus while those cases were going on. And so that kind of splits the focus. If you don't have a strong operative team, or if you're committed, think about it, those initial chest tubes wouldn't have gone in. Like, who would have been doing all of that? I guess we could have called our ED colleagues. But that's a factor. And then the other thing is, there were two things. One is that just always know that none of this planning happens on the night of, and that, like, for instance, I'm on the disaster committee at Jackson. We meet 4 or 5 times a year. We have drills going on. This is all like in place, maintaining those supplies. I'm thrilled that you had the pictures of that. That Lynn is also on the committee, but going through the city drills that happen often, we're not even, you guys aren't aware that the drills are happening a couple times a year. So that's all really important and part of this. But it was, except for our patient, who's doing the worst and making me sad. But thank you for taking him last night. And again, good job today.
Thank you. Thank you. Do you mind if I give you a quick phone call just to update you on last night?
Sure, go ahead. Super
Okay.
doesn't mind though. He's been a fellow here, he knows. But sure, go ahead, call me.
Oh, Dr. Super. Okay. Oh, that's right. I've heard your name before, and I didn't make the connection. I'm sorry. Nice to meet you electronically via Zoom.
Nice to meet you too. And nice to hear from you, Joyce. Okay.
Hi, you two, who is that behind you?
He's my son. He's my son.
Hi, I didn't know.
Yeah.
Nice to meet you.
Okay. See you.
Bye,
Bye bye.
good to see you. Sorry, Dina, go ahead.
All right. I'll give you a call now. Does that sound good?
Yeah, that's perfect. Thanks.
Okay.
Oh, wait, I have to turn off my phone. Oh, I have to make sure it's not on Do Not Disturb. Bye.
Okay.
1 sec.